Hello, everybody. I'm so incredibly happy and excited to be here. And I'm very excited to be sharing this topic with you all. For those of you that I am having the opportunity to meet and engage with for the first time, my name is Anthony Dissen. I am a professor at Stockton University in the School of Health Sciences in both our Bachelor's of Health Science program and our Master's of Public Health program. And I am very excited to be sharing this topic with you all today, role of cultural competence and cultural humility in the LGBTQ plus population for public health professionals. There we go. So a little bit about me. So as I mentioned before, I'm a faculty member at Stockton University. My scholarly work and research is specifically in LGBTQ plus health, as well as nutrition needs in particular. I'm also a registered dietitian nutritionist, both on the clinical side and public health side. So a lot of my scholarly and research work focuses on nutrition considerations, needs, awareness, et cetera, for the queer population, as well as just how the LGBTQ plus population, gender non-binary communities engage with our healthcare system in general. And then separately from that, I'm also personally interested in and fascinated by how health information is shared and utilized by people online, especially through social media, and kind of this ever worsening but also fascinating world of health misinformation. I am, again, very happy to be sharing this information with you all today. And just some of the objectives that I'm hoping that we will get across is to be able to better understand how these factors of discrimination, stigma, bias, et cetera, how a lack of cultural competence and humility has both direct and indirect impacts on the health and well-being across all dimensions of health and wellness for the LGBTQ plus community. To be able to better understand why this occurs. What are the ways in which these kinds of factors increase risk for chronic disease and illness, as well as how this leads to a lack of trust and a lack of comfortability in engaging with the healthcare system, both from a clinical and a public and community health perspective, and then how public health professionals, of course, can utilize this information and utilize concepts around cultural competence and humility to advocate for, support the health of, and reduce these health disparities of LGBTQ plus people. As questions, if you have questions that come up, please put them into the little Q&A box. Feel free to kind of just populate that as we go through. I'll make sure that we leave time at the end after I'm done sharing to kind of go through, and I'll answer questions at the end. But please don't feel like you have to wait till the end to put any questions into the Q&A. Feel free to share that as they come into your mind so that you don't forget anything. So a couple key aspects of terminology. And for some of you, this may be very familiar. For some of you, this might be relatively new information. And for some, this might be completely brand new. So I don't want to make any assumptions one way or the other about people's levels of awareness. So a couple key things to go over. There is a difference, although they are all related, between a person's sex assigned at birth, between their gender identity, their gender expression, and their sexuality. And the reason why I think this is important to share, especially from a public health perspective, is that what we are trying to do, especially with things around cultural competence and humility here, is to build trust. Because as we'll talk about, it is this lack of trust or the fear of being discriminated against, the fear of having biases projected onto a person that often cause people, especially in communities that have been historically and even currently mishandled by the healthcare system, that want to step back and say, I don't know if I want to come in for that screening, for this vaccination, for these kinds of cares that are being offered. So being aware of these key terms can actually be a very important way to build trust, to let people know that they are knowledgeable. So sex assigned at birth would be what is sometimes referred to as our biologic sex, although even that is sort of an outdated term, because even the whole notion of XX, XY chromosomes determining a person's sex is even itself becoming very outdated, as we're realizing there's even not even binary there, and there's actually quite a spectrum of how that presents itself. So sex assigned at birth is really more of the terminology that's being used now, because people are, in most cases, going to be assigned female, male, or intersex at birth. But then separate from that, and perhaps influenced by, but not necessarily influenced by a person's sex assigned at birth, is their gender identity. Do I identify as male? Do I identify as female? Do I identify as transgender, gender non-binary? For a person who is identifying as what we would call cisgender, cis meaning on the same side as, this is somebody whose gender identity is along the lines of or is the same as the sex they were assigned at birth. So if I was assigned male as my sex when I was born and I identify as male, I would be cisgendered. A person who is transgender, trans meaning opposite side, would be a person who is assigned male at birth or assigned female at birth, but their gender identity does not align with that. And they have moved, if we will, kind of to the other side, if you will, to the idea of I may have been assigned a female sex at birth, but I identify as male, etc. And then for people that are non-binary, gender non-binary would be a person who does not find themselves identifying with either male or female. And there's a whole slew of sort of diversity and spectrum in that as well. Then, of course, we have our gender expression. I might identify as male, but that doesn't necessarily mean my expression of my gender is always going to be what we would consider masculine. You know, there might be masculine aspects of myself, feminine aspects of myself, androgynous aspects of myself. And as my colleague and co-researcher, Dr. Liam Lair, would always say, the way that we can understand this is our sex assigned at birth, our gender identity and expression. This is who I go to bed as, kind of just my identity in of itself. Whereas a person's sexuality, gay, lesbian, bisexual, asexual, etc., queer, genderqueer, etc., might be more who I go to bed with. So the idea that my sexuality and my gender identity and expression are related, but they are separate. Just because a person presents in a particular way, just because a person identifies in a particular way, is not synonymous with what their sexuality might be. The other thing that I want to share for a general area of consideration is specifically for people who are transgender or gender non-binary. There are ways that we want to look through this lens in a way of understanding how the public health system can be more supportive. And one of which is to recognize that the idea of transitioning, the idea of having my gender identity transition from my sex assigned at birth can be viewed through three separate lenses. There is the social or societal lens, there's the legalistic lens, and then there is the medical lens. So from the social, this would be the just how I engage in the world, how I engage with my peers, the people I work with, my family. This is the name that I'm going by. These are the pronouns that I'm using. The way that I dress, the way that I present myself, right? These are social or societal aspects of transition. Then there are the more codified aspects of this would be the legal aspect. So legally changing my name on my license, on my passport, on my birth certificate, which is going to be a much more laborious process, but also a much more, a much more concrete process. And then if a person wishes to do so, there are the medical aspects of transitioning, which could be things like surgical intervention, pharmaceutical intervention, hormone therapies, etc. Not every person who identifies as transgender or gender non-binary is interested in one, two, or even all three of these aspects of transitioning. So one way that we can look at this through a public health lens is the environmental aspects. In what way does the environment in which people who identify as part of the LGBTQ plus community, in this case in particular, transgender and gender non-binary, in what way is our environmental structure supportive or non-supportive of these different aspects of identity and transitioning? What are the services that are provided or the lack thereof? So are there legalistic services in a community that can help people who are trying to go through name change, that are trying to have their passports and identities updated in the legalistic aspect? What are the support services from a social perspective? Clothing and clothing options. Pride events. I mean, here it is. This talk is happening in June. This is Pride Month. You know, does a person live in a community that has any kind of local pride, or is that something that isn't available to them? And then certainly, of course, medical aspects of the environment in terms of, well, are there healthcare professionals, both clinical and non-clinical, who are knowledgeable of things like hormone replacement therapy or other kinds of pharmaceutical therapy, surgical interventions, etc. Then there is, of course, the attitudinal aspects of the environment in terms of stereotyping and stereotype threat, which I'll talk more about in just a moment. Risks around social isolation, which, as we know, is a major risk factor for health conditions and disease risk across the board, as well as just a lack of understanding, a lack of cultural competence. The other aspects that we want to be very thoughtful of are the institutional potential barriers of employment opportunities. People who are part of the LGBTQ plus community, particularly those who are transgender and gender non-binary, and in particular those who are people of color, have higher rates of unemployment, higher rates of being denied housing, higher rates of being home insecure, food insecure, lack of access to health insurance, concerns around educational opportunities and access, all of which create a rather toxic potential cycle in which a person can find themselves unable to easily break out of, in which case we can see all the other social determinants of health and their other risks for health issues start to mount. Another two things I just want to put into our minds before we go forward, some different kinds of frameworks to think. So first is what we call the social model of disability framework. This is put forth by Mike Oliver and Ellie Clare. And the best way that I've ever heard this described, again, by my colleague, Dr. Liam Lair, is if I was driving down the road and I needed to get off of an exit, I needed to get into another road, and an exit didn't exist, I wouldn't look at my car and say, my car is disabled. I would say, build an exit, build a ramp to an exit. There is a structural social thing that is preventing me from doing what I need to do. But so often when we are talking about physical disability, or whether we're talking about other aspects of being marginalized, we view it as it's the person who is in lack, right? The person who is deficient in something. And so when we talk about LGBT health, we so often do see this through the lens of negatives. Risk for HIV, risk for this, risk for that, concerns. And it always sometimes is distilled down to, well, this is just because of a person being as part of the LGBTQ plus community that these are inherent. And they're not inherent. People are only disabled because the environment assumes certain levels of ability status. Well, so too is true of the health and social issues that can be plagued upon LGBTQ plus people. It is the environment, it is the societal factors. There's nothing inherent in that person that's putting them for an increased risk of disease or disability or injury or death. And then lastly, with this concept sometimes that comes up of intersectional feminist framework and others, what I want to put forward here is just the recognition that we are, all of us, you and me and everybody listening and everybody we engage with, we go through our lives in an intersectional way, meaning I am not just one thing. There are aspects of my identity that give me power in this world. There are aspects of my identity that take away power. There are aspects of my identity that are permanent, and there are aspects of my identity that change, in some cases slowly and in some cases quickly. And that's all of us. And so the health of an LGBTQ plus person is influenced by their identity as being a part of this community, but they're not just this one thing. So are they white or are they a person of color? Are they 25? Are they 75? Do they speak English as their first language? Is English not their first language? So these are going to be other intersectional factors that will increase or decrease their risk of health disparity and increase or decrease their access to the healthcare system. So the term that I'm going to be using going forward from here is this sort of umbrella term of queer community, queer identifying people, which includes a person's sexuality as well as a person's gender identity and gender expression. Now, for many people, this can sometimes be a bit of an off-putting word because a lot of us are used to queer being used in the pejorative sense. I have a link that I'll share at the chat when I'm done with my talk for the afternoon. That is a great breakdown of not just this term queer, but all of the different kinds of terminology that we might find under the queer umbrella that is put forward by GLAAD, the Gay and Lesbian Alliance Against Defamation. So I will share that link because it could be a really wonderful resource to have. But Just so you know, going forward, as I use the term queer, this is referring to people across the spectrum of both sexuality as well as gender identity and gender expression. Because what we're really talking about here is the recognition of spectrum as opposed to binary. So there are many different variations of this. Some of you may have seen this before. Some of you may have seen this in other forms. This is a graphic that was designed and put forward by the Trans Student Educational Resources, which is fantastic, and they've given me permission to share this. And the recognition here is, again, of spectrum. And this is the kind of thing we really want to keep an eye on and keep at the center of our mind when we are working with queer communities. And that is both the populations we work with, as well as colleagues, as well as ourselves, that there is a lot to consider and that we want to keep a more expansive mind. Because as mentioned before, there is our identity, there is our expression of that identity, there was the sex that was assigned to us at birth, there is our physical or sexual attraction, but there's also our emotional attraction. And no two people are going to be the same. There could be two people who identify as gay or identify as lesbian or identify as transgender or non-binary, but their movement through life is not going to be the same. One, because of intersectionality, right? They're all carrying the various aspects of their identity with them. But there's also, again, this spectrum in which each and every person is going to be finding themselves. So if there really is only one thing that I would hope anybody here would take away from this talk today or keep in mind, it is the idea of just having a more expansive idea and more of a curiosity of allowing people and communities of people to present themselves to you in their authentic way without kind of all of us going into that knee-jerk reaction of gay equals this, trans equals this, lesbian equals this, bisexual equals this, where we just box things in into more easily digestible, but often quite limited little containers. Why this is such an important consideration, and this is something that I think a lot of us forget or don't always consider, is that it is only in relatively recent history that the entire concept of being part of the queer community is not considered a psychological disease. It was only in 1973 that the American Psychiatric Association formally removed a diagnosis of homosexuality from the DSM. But what is important to know is that didn't, one, magically change anything, but two, just because this term homosexuality was removed from the Diagnostic and Statistical Manual, that was just replaced by new terminology. And it was only in the more recent DSM, I think maybe in the fifth DSM, where we really see kind of a purging of this notion that it is somehow a disorder or a disease or an impairment for a person to have any kind of same-sex attraction. The other thing to keep in mind is that it is also very recently that the World Health Organization removed its classification of homosexuality as a disease. But to this day, there is still classification within the ICD that the idea of being transgender or gender non-binary is still to this day seen as some kind of a disorder or seen as a dysfunction. So built within the DNA of our healthcare system, both locally and globally, there remains the echoes of, and in some cases, the very real presence that if a person identifies as part of the queer community, there is something wrong with them. And even if we were to say, no, but it's better, it's removed from the DSM, well, those scars and those wounds remain. And it is to this one of these very reasons why queer people typically remain silent about important health issues. Sexual health issues, mental health, as we'll talk about aspects related to body dysmorphia, eating disorders, et cetera, for fear of further stigmatization. Because the concern here is with the presence of the idea of homosexuality or gender dysphoria or all these kinds of terms being in these texts and in these diagnostic codes, well, that meant there was treatment. And this is where we see things like conversion therapy, shock treatment, and other kinds of therapies that were being used only until the last couple decades, where people are afraid that if they share this information with their healthcare provider, that they are going to be sucked into a system that is detrimental and traumatic to them. So as a result, many people who are part of the queer community would just rather not bring it up. I'm not going to talk about my sexual practices. I'm not going to talk about concerns I have about eating disorders. I'm not going to talk about maybe use of things like chemsex, like the use of amyl nitrate and other kinds of methamphetamines and other kinds of products. I don't want to be discriminated against. I don't want to be judged. And so we remain silent. The other aspect that's very important to consider when we're looking at this from a public health perspective is this notion of what is referred to as heteronormativity. And what heteronormativity refers to is sort of the systematic wide assumption of a person's sexual orientation and a gender identity defaults to heterosexual and cisgendered. So the idea here is even look at intake forms. If we're looking at this often from a clinical perspective, if someone's filling out a form, but in any kind of way, they might fill out information to enter the healthcare system in some way. It assumes male, female. I, to this day, have never seen a medical or a public health or any other kind of intake form that allowed intersex as an option for a person to check off. It assumes that if you are male, you are immediately sexually and emotionally attracted to a female and vice versa. It assumes that if you are transgender, you are immediately looking for gender affirming care through surgery or hormones. And so there is this idea that built within the healthcare system, it assumes straight, cisgendered. So this can lead to prejudiced attitudes and discriminatory practices, further disenfranchisement, further lack of commitment, further lack of care, and a greater risk of mistreatment. The other thing that can come up with the issues of heteronormativity is that it can lead people to, again, want to stay silent. So if I can share just a brief experience from my own experience with the healthcare system, this was several years ago now, but I remember seeing a physician for the first time who's going to be a new primary care physician for me, going through the kind of normal things of health history, et cetera. And on the form I had said I was married. And so my physician said, I see you're married. What does your wife do? And I said, well, I don't have a wife. I have a husband. He said, oh, let's order an HIV test. So in my mind, in that moment, he immediately equated gay equals AIDS, gay equals HIV, before asking me a single question about HIV, about sexual health status, about sexual health history, or 1,000 other questions I could have been asked. It was that immediate assumption of, oh, this male presenting person is married, must be married to a woman. And when that was switched to say, oh, they're married to a man, big red flag, HIV. That was embarrassing. I remember very clearly walking through. I felt very embarrassed by that. And frankly, he did not stay my healthcare professional for very long, not because he was necessarily a bad physician, but because I immediately felt embarrassed and distrustful of him. How can I share more details about myself and my health needs if my fear is I'm immediately going to be judged or just that an immediate assumption is going to be made? So with heteronormative assumptions, when we talk to people in communities and in healthcare environments, and we make assumptions or we disregard, we use shaming kind of languages around sexual health practices, et cetera. These, again, have that 1-2 punch of I'd just rather not engage with the healthcare system in general, or if I do, I am extra afraid of being discriminated against or prejudiced. So I'm just not going to share everything that needs to be shared. What this can lead to is, again, is what is referred to as stigma consciousness, which is the level to which people are aware of. And the healthcare organization, particularly public health, we really need to be aware of how often people have stigma consciousness, especially in communities that have been historically mistreated by the healthcare system, by county health agencies, et cetera. And so we need to do a lot of restorative work and a lot of healing work to allow communities to feel like they can trust health organizations and that health organizations have their best interests in mind. The other thing we want to be very aware of, both as the individual level as well as any organization we work with, is the notion of microaggressions. And microaggressions are typically subtle, indirect, and often unconscious moments of discrimination against any kind of group. Now, these can be in the form of what we call micro assaults, where people act rudely, speak rudely, move away. Again, often unconscious. So if I'm speaking to someone and they come out to me and they tell me that they're a member of the queer community, and my body language just immediately goes back a little bit, or I kind of close off, that's a microaggression. That's a micro assault. Maybe it didn't happen with an overt malicious agenda, but in the mind of that person who witnesses, they're going to say, oh, I can't trust this person. I can't talk to this person. Having a sense of erasure. This is actually something that comes up quite a lot. I treat everybody the same. I don't need to know about a person's sexuality. I don't need to know about a person's gender identity. It doesn't matter. I treat everybody the same. Well, as we'll see, not only is that not helpful, because I need to know about all aspects of a person in order to provide assistive care or to be able to provide them the resources they need, that is a form of erasure. That is a form of me saying, your identity doesn't exist to me and it doesn't matter to me. Micro insults. Oh, you don't seem trans. You don't seem gay. I'm surprised. You look so good for a person. Little things like that are maybe, again, not meant to be insulting, but they are. Assuming a prior history of abuse. Did you run away from home? Were you sexually assaulted as a child? People have said this to me. People have said this to friends of mine. I've seen this happen shockingly regularly. These are forms of microaggression. And then also micro invalidation, which is the notion, again, of doesn't matter. I don't need to hear about it. Don't ask, don't tell. Don't be so sensitive. This is just a confused phase you're going through. Something that somebody said to my face once, well, I hate the sin, but I love the sinner. All right, I'm not sure what I'm supposed to do with that information, but I guess thank you. Right, another way of saying your identity, your truth doesn't matter very much. So this is where public health professionals need to be actively going through the process of dismantling these problems, because if we want communities to open up, to trust, to share, to participate, to engage, they need to know that in doing so, they will not be further discriminated against, stigmatized, or traumatized in any significant way. Because this mixture of societal and structural barriers, the kind of interpersonal stigma, as well as the intrapersonal stigma. Many people are carrying within them internalized homophobia, internalized transphobia. As Alan Downs, who wrote the wonderful book Velvet Rage, would say, many people in the queer community are walking around with the wounds of self-hatred within them, this sense of, I wish I didn't feel different in this world. That needs to be deeply understood and supported in order to address the health inequities that we see within this community. As I was mentioning earlier, the ways in which access to care, the way in which access into the healthcare system can be impaired and blocked, can be through the form of outright discrimination, lack of awareness, lack of knowledge, lack of competency of providers, researchers, advocates, et cetera. Lack of access to employment means lack of access to health insurance and different kinds of policies. And we're seeing this happen in real time right now. Different states, different organizations and employers are radically closing down and limiting whether they will support with their medical insurance gender affirming care, whether they will support the employment of people who publicly come out as gay or trans or queer in any kind of way. The access to care is heavily dependent upon a person's income and their employment status. We know this. And we know that being not only part of the queer community, but actively socially involved further increases the likelihood of potential discrimination. An example that I always like to share with this, for those that may be familiar with PrEP medications. PrEP stands for pre-exposure prophylaxis. These are medicines that are incredibly effective at preventing HIV transmission from an infected to a non-infected person. And as much as we can never really say this, right, in science and in healthcare, they're essentially asterisk, but essentially completely protective. And the research that has been done, people who take their PrEP medication, there's never been a case of a negative HIV negative person who's taking their PrEP medication as directed who has become infected with HIV. It's incredible. And yet, when these medicines, Truvada, and now we have Descovy and Apretude and others, came onto the market, there was a term that was being used in media and in research called Truvada whore, with the notion that we as healthcare professionals shouldn't be prescribing Truvada, which was at the time the only PrEP medication available, because this will just be a green light for people to be sexually promiscuous, which, interestingly enough, if we look at this through a historic lens, right, is the exact same language that was used when birth control medications. Physicians shouldn't be prescribing birth control medications to their female identifying patients because that will just give them excuse to be sexually promiscuous, right? And this wasn't just journalists. I mean, there were physicians and nurses and other healthcare professionals out there saying we shouldn't be supporting this medicine that literally prevents HIV, because it will just lead to more sexual promiscuity, which is terrible. Now, thankfully, over the last decade or so, this has not only changed, but there are more PrEP medications available. But it still is this notion that for a queer identifying person to have any kind of sexual experience, any kind of sexual pleasure, any kind of sexual ownership, it is immediately seen as a negative. The other thing to be aware of, and this is really an area that, again, that a lot of my work is involved in, but in anything that we're working with queer identifying people, there are very high rates of disordered eating, body dysmorphia, lack of body satisfaction. This is especially worsened in people who are queer and also of color. There are many reasons for this. We don't have the time to go too deeply into this today, but we want to be thoughtful of this, especially in gay and bisexual men. We see very high rates of things like extreme dietary fasting, exercise-induced fasting, purging behaviors, etc. These are questions and things we want to be extra aware of. We see all sorts of different kinds of increased risk of other kinds of disease states and disease risk, things like diabetes, coronary artery disease, angina, stroke, myocardial infarction, certain types of cancers, et cetera. And we might say, well, why? What does a person's sexuality or a person's gender identity have to do with any of this? Well, half of that coin is the stress, the very real stress that people feel. But the other half of it, again, is access. People who are queer are less likely to be getting routine physicals, are less likely to be having a routine care provider to get screenings because of fear of being discriminated against by the medical and healthcare community. And at both ends of the spectrum, as far as age, queer identifying youth, as well as queer identifying older adults, are much more likely to be homeless or home insecure than their heterosexual and cisgendered counterparts. All of this is due to stigma and due to a lack of trust. And all of this can be highly remedied through a public health and community health perspective by providing care providers and other members of the public health team with the knowledge needed to be a safe space, to be a culturally competent and supportive care provider themselves, as well as to recognize and kind of nip in the bud the things that can lead to that fear of stigma that would cause people to not want to engage with the healthcare system. So there's two models I just want to very briefly share. The first is what's called the cultural competence practice model, and the second is the cross model. So the idea is, how do we become culturally competent, whether we're working with queer cultural competency, race-based, language-based, age-based, whatever kind of area of competency we're looking at. First, we must become aware and do what you're doing right now, which is to do the kind of self-exploration, the thought, the education needed to become more aware of the need for knowledge and competence around a particular cultural identity. What are the values? What is important to people who are transgender or gender non-binary or intersex or lesbian or gay? Have I ever asked a person who identifies as lesbian, gay, transgender, genderqueer, intersex, etc., what is important to you, both as a person, but as a queer identifying person? What is your value system? And actually allowing people to share their narratives and their stories. Knowledge acquisition, again, actually finding out what is the knowledge, what can I do in order to see how these value systems are a strength within that individual, and then start to change and match my skills. What does my health center, what does my clinic, what does my community health agency, what does my educational setting, right, wherever it is that I work and operate within public health, how do we make sure our services match the needs, match the values and the strengths of the people we're hoping to work with? And then to engage in what is called inductive learning, which is actually including what we might call community-based learning, right? Actually working with people and saying, not just, we're going to kind of force you to do what we think you need to do. How do you make sure we are learning and learning what we need to learn from you in order to make sure that we're actually providing the care that we need? Very often, this is done by actively hiring, recruiting, and retaining people who are part of that culture and part of that community, in this case, the LGBTQ plus community. The other thing I just want to briefly share is what's called the cross model for cultural competence. And what this shows is the spectrum and the process by which a person or an organization goes from being completely lacking in competence to being quite proficient in their competence. So at the most negative end of the spectrum, we would see cultural destructiveness. So an example of this could be, I do not work with people, I do not treat people who are part of the queer community, right? I don't engage with people. That would be actively destructive. I find a lot of people, though, tend to fall more in what we would call culturally incapacitated, where they may have a desire to help, but they don't have the resources, the knowledge, or the skills to help. From here, we again might see what we talked about at the beginning, that erasure, or that what we sometimes call in the cross model cultural blindness. I treat everybody the same. My colleagues and I just did a study of dietitians in the state of New Jersey about their LGBTQ plus competence. And one of the common things we saw, which was not a surprise, I don't need to know. I treat all my clients the same. No, you need to know, because especially in this case, as a nutrition professional, you need to know about increased concerns, body dysmorphia, eating disorders risk, body dissatisfaction, concerns around increased risk of diabetes, heart disease. You need to know these things. Increased risk of food insecurity, home insecurity. Those are things that a nutrition professional needs to know. And yet many people say, it doesn't matter. I don't need to know. It has nothing to do with my work. If we're able to move beyond this, though, now we can engage in what is called pre-competence, which is actually starting to improve and match some services to the care that is provided. A good example would be Pride Month's event. They're a good place to get started, but what we need is full competence, where now we have active representation. We have adapted our policies, procedures, our skills, and our services to match the needs and to match the value systems of the people we're working with. And then at the most positive aspect of this, we would have what we call multicultural proficiency, where we are now championing this culture by recruiting people, doing research, presenting at conferences, giving webinars, right? Things that look what's happening right here, right? Actively championing the advancement of cultural competence for any particular community or group. The other thing that we need is what is called cultural humility. And cultural humility is self-reflection and inquiry and staying silent and letting other people's voices come through. So to be a culturally humble person, yes, I want to be competent, I want to know things, but knowledge can sometimes give us that knee-jerk reaction of kind of always putting ourselves in that expert role where we think, I don't have anything else to learn, I'm going to tell you. I want to let my transgender and my non-binary and my intersex and my queer identifying people share their stories with me and listen. So how can I further reflect on when I find myself maybe committing a microaggression and someone shares something with me and I do that back up? If I'm culturally humble, I might say, I wonder why I did that. Why was that my reaction? And can I do the kind of self-reflection needed to find out why? Because if I can do that, I'm building awareness of my potential personal biases that all of us possess. I am staying flexible to new ideas, new concepts, and perspectives. And I view what we're supposed to be doing in healthcare, right, is lifelong learning and lifelong unlearning, and creating a healthcare and a public health system that is more equitable and less hierarchical in nature, which can leave people feeling disempowered and disenfranchised. So questioning and doing that kind of self-reflection is how we become more culturally humble. One thing that I often ask people to do, both my own students, as well as just anytime I'm speaking about this to people, what are the aspects of my identities that I'm most aware of, least aware of? What are the aspects of myself that I think the most about, least about? What were the ones that were emphasized the most to me growing up? What are the things about myself I wish I knew more about? Just because I identify as part of the queer community doesn't mean I know the first thing about queer culture. Maybe I need to know more, but I don't know that if I don't ask myself those questions. What are the aspects of myself that I think other people misunderstand the most? Or what are the aspects of myself that are most difficult for me to talk to people about, even people I'm close with? To do this, not just for myself personally, but then to bring this into my organization, to bring this into my classroom, to bring this into my interactions with other people. This is what it is to kind of build that multicultural proficiency and improve cultural humility. Because by asking ourselves and others these kind of self-reflective questions, it takes us out of a expert role and it takes us out of that authoritative role and allows us to be on even playing field and an even level with everybody else. What I'm always trying to encourage people to think about is how we move from a less pathogenic model of public health practice to a more salutogenic model of public health practice. And yes, we need our biostats and our epi, and we need to know the pathogenesis of diseases. Those things don't go away. But if I view queerness through a pathogenic lens, the same way as if I view Blackness through a pathogenic lens, or I view a person's age status through a pathogenic lens, I am probably more likely to treat a person and their identity through the lens, again, of the negative. If we can incorporate more of a salutogenic model, which are what are those supportive health promoting factors that are at the root of your culture, of your sexual identity, your gender identity? How are these things part of what your assets and what matters to you? In what ways are you grateful to be part of the queer community? In what ways have you found empathy and belonging within the queer community? How has your quality of life been enriched because of your queerness? And then how have even the things you've experienced that have been disparities and sources of trauma, how have they helped to facilitate that post-traumatic personal growth? How have they strengthened you as a person over time? This is a very different way of communicating with people versus how has this made your life harder? Or these are the things we're worried about because you are part of the queer community. It's a very delicate shift. And again, it's not to erase the need of knowing about health status, disease status, infectious disease risk, et cetera. But we don't want that to be the only way that we talk about or think about or communicate with people who are part of the queer community. So the more that we can do that self-reflective work, build our competence and knowledge, and think about these intersectional models and frameworks to really create communities and environments that are supportive, that are advocating for, championing members of the queer community. This creates a very different space that queer people can find themselves in, and in this way, become much more trusting of and much more willing to engage with and open up to members of the health community, whether they are in a solely public and community health perspective, as well as anybody who might also be more in the clinical side of the house as well. These are some excellent tools which you may want to learn more about. Trauma-informed care for trans and gender diverse individuals with Jenner Potter, as well as the agency self-assessment tool for those that do areas of research. Excellent, excellent, excellent tools. A couple other quick resources, then I'll open things up for Q&A. If you would like to keep building your knowledge from here, I highly recommend these resources. The National LGBTQI+ Health Education Center is fantastic. The Equity Federation, SAGE USA, which specifically advocates for queer seniors. PFLAG, which used to stand for Parents and Friends of Lesbians and Gays, but now is just sort of a general community-based supportive network for anybody who's part of the queer community, including family and allies. The Trevor Project, as I mentioned before, The Velvet Rage by Alan Downs is still a classic. And especially for anybody that might be interested more on the idea of body image, body satisfaction, and body identity, Looking Queer by Dawn Atkins is a really fantastic, wonderful resource. So I'm going to stop sharing there, and I'm going to open up the chat here to see what has been asked. And before I do that, I just want to quickly share, because I know I'll forget, this is the link to the terminology that I had mentioned from GLAAD, if you're interested in learning more about some of these terms. So I see a couple questions here. So when is someone that transitioned M to F, male to female, just considered female, not trans? That is an excellent question. That's a really good question. And so what's being asked here is, if I was assigned male at birth, that I have transitioned or am transitioning to a female identity, um, can I not just be considered female? As do I always have to be considered a male that transitioned to female, or a trans woman or a trans female person? That's a great question. So two different things I would share with that. One of which is part of it really comes down to the individual person, because there are people in my life, people that I know that are transgender, that really embrace being transgender. And for them, it is actually a very important distinction to let people know they are a trans woman or a trans man, because that is just an important part of their identity. Whereas I can also think of some other people I know that just want to be seen and considered and identified and acknowledged as male or female. So I think part of that answer to that really good question would be asking them, like, do they want to be seen as or identified as or spoken as a trans woman or a trans man or a trans person? Or is that something that is not necessarily part of their identity that they really want to emphasize? The other aspect of it is, if we're looking at this, their health through the medical model, knowing that they are a man who was assigned female at birth or a woman that was assigned male at birth, I would want to know, or healthcare professionals may want to know, that just because I may be a trans man or a male identifying person, but do I still have a uterus? Do I still have a cervix? Do I still have ovaries? Right? There might be aspect of my care, and saying, am I a trans woman, but I still have a prostate? Have I necessarily undergone other kinds of medical transitioning or not? So there is, I think, part of that question, we would say, from the medical perspective, we might always want to consider their trans identity as an important factor, because there might just be necessary aspects of their medical care to understand more anatomically what they're bringing into a healthcare situation, as well as did they undergo surgery? Are they using hormone therapies? Those sorts of things. But from that social model, just how a person is existing in the world, I would say it very much comes down to that individual person. Do they want to really celebrate and have their transness recognized? Or is that not something that they're necessarily trying to emphasize, and they would prefer to just be known as male or female in that way? And again, that would be something that if a person is comfortable enough to share, that we would want them to share, how would you like to be seen, to be acknowledged, to be identified? And yes, Vanessa, I see your comment here. I will make sure that a copy of these slides are made available, because I know there's a lot of information and we only had the hour, so some of it was gone through rather fast. So yes, that will absolutely be made available. Great question about queer intake forms that are inclusive of queer identities. Yes, and so that is something that the National LGBTQIA Health Education Center does share. That was one of the resources that I had shared before. They have some great examples of how intake forms can either be just copied, or how they can be changed based on wherever it is that you may work, to be more inclusive of language. There's another organization I didn't mention, but it's called GLMA, which used to be an acronym for Gay and Lesbian Medical Association, I think, but now it's just GLMA. So if you look up GLMA, they also have some great resources and some materials about how to make sure intake forms, medical history forms, et cetera, are inclusive in that way. Thanks for the, okay, about medically, how this is found out, if my trans daughter is brought, oh, excellent. Okay, so as a follow-up to that earlier question, so again, if someone was being brought to the emergency room or something like that, again, that is where the evolution and the adaptation of intake forms. And this is something I should have shared before, so I'm glad that you're asking this question, because it's reminding me to talk about it now. This kind of language and questioning really needs to be universal, because I think, and again, if I'm understanding your question correctly, well, if I think I should only be asking queer people about their sex assigned at birth, their gender identity, their pronouns, how am I going to know that? Unless a patient comes into, if we're talking about this from a clinical perspective, if a patient comes in and says, hey, before we get started, I just need you to know all this about myself, how would I know? But imagine if this was every question that was asked of any patient. What was your sex assigned at birth? What is your gender identity? What pronouns would you like me to use? And it just becomes, for lack of a better word, I hate this word, but if that just becomes normal, that's just how we talk to people when they enter into a healthcare situation. Right? That would really start to change things, because then it further removes us from this idea that it's only this community that should be asked this question, or it's only this community that should be asked this question. Anything we can do, and if we're looking at that through that cross model, that's where that multicultural proficiency really starts to come into, of this is just standard health practice now. The same way that everybody, when they go in for a physical, should be asked, would you like an STI test? Not just those people who I think are at higher risk of STIs versus other. It should just be standard approach. Are you interested in STI testing, or something to that effect? So I think that is really how we solve this dilemma that you're talking about there. Is we won't know if we still think I have to guess who may or may not be part of the queer community, or I wait for a person to self-identify as part of the queer community before I open up that part of my brain and start to ask those questions. And I very much agree with your comment there, Charlotte. Thank you. Right? If this just becomes the universal approach and a more consistent approach, it helps everybody. Because, and this isn't something that I spoke about too much, but there's a phenomenon that we sometimes refer to as bisexual erasure, which is sort of, again, the idea that people who are bisexual, or people who don't just, perfectly fall into gay or lesbian or these kind of definitive camps, can be lost. Because what if I'm a man and I'm married to a woman, but I also identify as a bisexual person? And maybe between my wife and I, we have a consensually non-monogamous relationship. And I sometimes have sexual encounters with men, but my healthcare professional just looks at my chart, sees me as a male identifying person, sees that I'm married to a woman, and thinks, this guy's straight, and I don't need to ask him any questions about HIV or anything else, because he's just being sexually active with his wife. Right? People are harmed by these assumptions. And so absolutely, if this becomes universal and standard, are you interested in HIV testing? Are you interested in esophageal swabs and rectal swabs for STIs? If that just becomes standard questions for everyone, it normalizes the conversation and the question, and it allows things to be more easy to come by. And Queenie, I see I was literally just open the Q&A, so I see you posted it here as well. So thank you for that. So can I speak more about the higher rates of disordered eating and body dysmorphia in queer people of color? Has research been conducted to explore what's driving these behaviors or perceptions in queer people of color? Great question. Part of this, part of the reasoning and part of the rationale we're starting to recognize why we see these higher rates, particularly in body dysmorphia and eating disorder, is in some part driven by different kinds of smartphone apps. So if anybody is familiar with certain apps like Grindr, Scruff, Sniffies, these sorts of things, these are apps that people use in some ways, people might be using them for dating or romantic aspects, but for a lot of people, they are purely sexual hookup apps, right? These are ways to find people for sexual connection. Well, the way that a lot of these apps are designed is they use what is called the grid, where you just see pictures of people, and maybe it's just their face or whatever profile picture they've put up with a couple key things. And the idea is that the people who are seen as more sexually desirable, the more sexually attractive, the more sexually sought after, will be more lucky on the apps and have more of a greater chance of being selected for some kind of sexual connection. Some colleagues of mine and I just recently published a study in the last year or two that looked at specifically what you're talking about here. And what we found was that people who used apps like Grindr more regularly had higher rates of body dysmorphia and higher rates of orthorexia nervosa, which for those who may not be familiar is an unofficial form of eating disorder. It's sort of being worked out whether it will ever enter the DSM, but it's this notion of being kind of unhealthfully obsessed or preoccupied with eating healthy food. And what we found was that people who were on these apps more had higher rates of this dysmorphia and potential disordered eating issues for the idea of being more sexually desirable. Why this impacts people of color potentially more is people of color by default, because of how these apps and other things are designed, we know are less likely to be seen as sexually desirable, or are more likely to kind of be put into negative categories. And so there can be an even greater heightened need to have high muscularity, very low body fat, have this sort of perceived notion of being a very sexually attractive person in order to be seen as worthy of attention on these apps that a person who is white or not a person of color might not have to worry about quite so much. And so that's where some of the research seems to be pointing right now, is that especially for queer people of color to be seen as sexually desirable, there can be an even heightened preoccupation with muscle size, body fatness, skin blemishes, these sorts of things, and that can lead to a greater preoccupation with perceived bodily flaws and greater potential disordered eating risks, hyperexercise, et cetera, to try to be as sexually desirable or as sexually attractive as possible. That at least seems to be some of the research that's really coming out a lot right now, is, for lack of a better way of saying it, trying to keep up and trying to keep sexually desirable because of this notion of what a sexually desirable queer person is supposed to look like. These are all excellent, excellent questions. Before we begin to close up for our hour, any final thoughts, comments, questions? If you have anything, please feel free to put it in the chat or the Q&A. And again, I will make sure that these slides are available for anybody who might like to refer to them in the future. Thank you, everybody, for being here. We had such a great number of participants come in, and I greatly appreciate the kind messages that are coming through. I'm glad that you found this helpful. And yes, absolutely, colorism, fat phobia, these sorts of things. I'll do a quick plug for a great organization called WIND, Weight Inclusive Nutrition and Dietetics. For anybody that does work in things related to food and nutrition and wants to do so from a weight inclusive lens, check them out. Otherwise, thank you. Again, I hope that this has been helpful and something that will aid you in your own profession. And my deepest thanks to the National Board of Public Health Examiners for giving me the opportunity to share it with you all today. Thank you.
That was wonderful. Thank you, Dr. Dissen.
My pleasure. Be well. Thank you again.
Bye-bye.
Bye-bye.